Next speaker is Dr. Tian. She's a pediatric hematologist oncologist at Texas Children's Hospital. She finished her fellowship at Baylor College of Medicine down in Texas, and her focus is on developing cell-based immunotherapy for pediatric malignancies. And she's going to talk today on NKT trial update and a new immunotherapy that is going to be opening at Texas Children's. Dr. Tian. Slides.
Oh, sorry. Well, hi everyone. So I'm from Baylor, and I'm part of the big cell and gene therapy group over there. And I'm going to talk about two studies that's from the CAGT Center in Baylor. That's kind of a cell-based immunotherapy to target neuroblastoma. And one trial, the upper one, it has been open since 2018. So I'm going to give some updates on some of the results. And the lower one, it's the one that hasn't been open, and it's going to be open hopefully by the end of the year. I have nothing to disclose. So just a brief introduction about what is adoptive cell therapy. As Francesca yesterday gave a good talk about the excellent work that's done in Rome. So compared to the conventional cell therapy, conventional therapies, we think if we take the cells out from a patient and engineer the cells, the T cells or other immune cells to express a molecule called CAR, chimeric antigen receptor, and then also expand the cells ex vivo to large amount, then we can reinfuse the cells back to the patient. So when the cells go back to the patient, they can recognize the cancer through the CAR molecule and kill the cancer cells. We have seen great success in using CAR T cells to treat leukemia and lymphoma by the CD19 CAR. However, there are limited success in using the CAR T cell approach to treat solid tumor in general, including neuroblastoma. We think there are several obstacles for the CAR T cells to execute good anti-tumor response. First, for the T cells to go from the blood vessel, find the tumor, get out of the blood vessel, and go into the tumor site. And also, at the tumor site, besides the tumor cells, especially in neuroblastoma, there are stroma cells that include several cell types that they constantly produce cytokines and also molecules that can inhibit the T cell function and support the tumor growth. We are interested in different cells called natural killer T cells. It's also in the blood and bone marrow. And we think there are several advantages of using the NKT cells compared to the T cells. As I've shown here, so the NKT cells on the right, it recognizes a CD1D molecule on the target cells presenting a glycolipid. So what's make it unique with NKT cells compared to the T cells is the CD1D molecule is the same. So my CD1D is exactly the same as yours, which means my NKT cells can be potentially expanded and as a donor cells and infused back to the patient. Versus on T cells, we really couldn't do it without the MHC match because everybody's HLA molecule is different. So if you use a donor T cells and give back to the recipient body, if they are not a HLA match donor, so you're going to have graft versus host disease. We also found that the NKT cells, they can localize to the neuroblastoma site more effectively than T cells. So this is done in the preclinical mouse model that we have the tumor cells stained with blue, so all the blue are tumor cells, and our T cells or the NKT cells are stained with a green dye. So the little green dots are the T cells or the NKT cells. And you can see when the cells are not modified to express CAR, the T cells doesn't really go to the tumor site. However, the NKT cells, even without CAR expressing on their surface, you can see a decent number of infiltration. And with the CAR molecule expressed, the T cells does go to the tumor. We do see a more enhanced NKT localization to the tumor when they express CAR. So with that, we tested multiple constructs of the GD2 CAR molecule and test preclinically how they can kill tumor in a mouse model, in the tumor-bearing mice. So we tested a multiple construct, and the construct we saw that has the best performance is a GD2 CAR with a CD28 zeta endodomain. And also we co-expressed the L15 molecule, which is kind of a cytokine that can support the NKT growth and persistence. So our theory is if the NKT can persist longer in the patient, they can kill one tumor, go to the next one, and then they can kill more tumor cells. So based on this data, we selected the GD2 CAR with CD28 zeta domain and L15 as our clinical construct and opened our first phase 1 clinical trial of using the GD2 CAR expressed on the autologous NKT cells to treat patients with neuroblastoma, also known as GenaKit. So for this trial, so it's relapsed or refractory high-risk neuroblastoma patient, and before we give the cell therapy, we do lymphodepletion, which is pretty standard for all the cell therapy, either for neuroblastoma or other leukemia lymphomas. So the reason for the lymphodepleting chemo, it's not really to kill the neuroblastoma, and the dose of cyclophosphamide is much lower than what we use to treat neuroblastoma. So the goal of the lymphodepletion is to empty the bone marrow a little bit, so when the new cells come in, they can have nutrition and a growth factor to help them grow. It's a phase 1 study of initially designed for those dose escalation. So we start with the lower dose to ensure the safety before we move on to the next dose level. So we have completed the 4 dose levels, and we added 2 additional dose levels. The goal of the trial is to evaluate for the safety as well as the anti-tumor efficacy of our product. We are also interested in see how the NKT cell persists in our patients and also traffic to the tumor site. So I'm going to first talk about the data we have for the 4 dose level on 12 treated patients. So this is the trial design. We gave 3 days of chemotherapy as a lymphodepleting regimen, followed by CAR NKT infusion, 1 single dose. Then weekly, we'll observe the patient. We'll follow up with the patient in clinic. We do require a week 2 biopsy, a tumor biopsy. And by the end of the 4 weeks, so the patient and the family can go back to their home institution and have imaging and evaluation done at their home institution. And I do want to mention that there's no scheduled admission, so everything would be outpatient unless the patient has side effect from either the chemotherapy or the cell therapy. So this is the adverse event of the first 12 treated patients. So, and on the right side, the 3 and 4 are grade 3 and grade 4 of each adverse event. And the number represents how many patients out of the 12 patients have that adverse event. So you can see the upper part is basically cytopenia, anemia, leukopenia, neutropenia. We think it's most likely related to the chemotherapy instead of actually our cells. We do see some more like cell therapy specific adverse events such as cytokine release syndrome, but we only see grade 1 in the 12 treated patient, and it's managed just by conservative and supportive care. This is the clinical responses of the 12 treated patients on 4 dose levels. So out of the 12 patients we treated, we have 3 patients with objective responses, including 2 with partial response and 1 with complete response that lasts for 10 months. On top of the 3 patients with objective responses, we also see 2 patients with a clinical response, but it's not adequate to call a PR. So including patient number 3 that his score went from Curie score went from 7 to 5. So we do see some responses, but it's just not adequate to be a PR. And also for patient 11, so he had bone marrow disease at the enrollment, and the bone marrow was cleared at the end of 4 weeks. So this is just one example of the MIBG imaging for one of the patients treated. So the upper part is the pre-infusion MIBG. So you can see there is a big, kind of a very obvious MIBG avid lesion on the sternal bone on the chest. And here it's just a heart imaging, so it's not really the tumor. By 4 weeks, you can see that lesion got much smaller. We waited for another 4 weeks and repeat imaging, and you can see by then you barely can see the lesion on the sternal bone. Regarding the timeline of the NKT enrollment, so since it's autologous, meaning the cells are from the patient itself, so we have 2 phases of the trial. So the first phase is called procurement. Basically, that means you allow us to take the cells from the child and through the apheresis, and allow us to manufacture cells. So day 1 is a clinic visit with consent and the lab draw, and the day 2 will be our interventional radiologist will put in the apheresis line, followed by outpatient apheresis and the line removal on the same day. So usually our patient would be able to travel back home on day 3. And then there are 8 weeks waiting period. So it's 2 weeks of cell manufacturing, and by the end of the cell manufacturing, we'll freeze down the cells. And then we have 6 weeks of different testing, so to make sure the cells are pure, are sterile, and are doing, at least in the Petri dish, what they're supposed to do, that's killing tumor. We do recommend some bridging chemotherapy because most of the patients we got are pretty refractory and has high disease burden, so we do want to make sure that they're in a good spot to start the treatment. And I do want to mention that the 8 weeks, approximately 8 weeks is a minimum time that we have to wait before we can infuse the patient, but the cells will be frozen for years. So if someone want to go on other therapies, so the cells will be there. So when I kind of see this as a safety net, just in case the child needs it in the future, so the cells will be ready to go. And it's kind of especially important when someone's planning to get MIBG therapy, because MIBG therapy, even after stem cell rescue, can take a long time for the lymphocyte to recover, sometimes up to 6 months. So, and it's a lymphocyte population in the blood that we're interested that we can manufacture the cell from. And the second phase is called the treatment of the NKT cell therapy. So I've shown this before. We do imaging and the bone marrow biopsy prior and after. And then, basically the patient has to be local in Houston around Texas Medical Center for up to 5 weeks, including 1 week of treatment and 4 weeks of observation. Mainly because after the cells are infused, usually the CRS or cytokine release syndrome will happen around those first 4 weeks. We also require 2 additional CBC for the first 3 weeks. So after we treated the first 12 patients, we went on to dose level 5. The first patient on dose level 5, unfortunately, had a lethal hyperleukocytosis. So his cells grow a lot in his body, and eventually he had multi-organ failure and passed away. So we shut down the trial for 8 months. We did extensive root cause analysis. What we found is he's the first patient on dose level 5. He's also the first patient received the cells with a modified cell manufacturing protocol. We changed the protocol initially because a newer protocol gave the better quality of cells to persist longer in the patient. However, unfortunately for him, this uncontrolled growth caused his multi-organ failure and death. I do want to mention that this patient, for the autopsy we did on this patient, we did see a disease, kind of a treatment response, meaning they did see kind of a lack of the absence of the neuroblast in the patient. So we shut down the trial for 8 months. We did cause analysis, root cause analysis. We submit to the FDA. The FDA gave us a green light to restart the trial or resume the trial with a proposed mitigation plan. So what we're doing now is we revert back to the original manufacturing protocol that's been saved for 12 patients. We include one autonomous growth assay at one of the release criteria, and that assay takes about 4 weeks. That's why it takes about 6 weeks total for the cells to be tested. And we have a treatment plan if this happens again. So we have a treatment plan of using steroids, other chemo to control the cell growth. And also FDA requires us to have a CBC 3 times a week for the first 3 weeks, and mainly just to observe how the white cells change over time. And if we do see a cell replicating fast, we'll have the patient admitted and have closer observation. There are 2 additional patients treated on this dose level, and we did not see any dose-limiting toxicities or the hyperleukocytosis that we saw on this patient. However, both patients had progressive disease. So that leads to our next question. So we did see some responses from some patients, but some other patients did not have any have progressive disease. And one of the things that we kind of published recently from the clinical preclinical work is that we know for the neuroblastoma, besides the neuroblastoma tumor cells in the tumor, there are also other cell types, including monocyte and macrophages. So those are the cells that can support the tumor growth. We actually found the mechanism that is through this TNF-alpha molecule. So by engaging the neuroblastoma cells with the monocyte through this molecule, the monocyte can actually produce L6, and the interleukin-6 can further enhance the neuroblastoma growth. Additionally, when we give the CAR NKT to the patient, upon the CAR engagement, NKT is also known to produce soluble TNF-alpha, and the TNF-alpha is also the driver for cytokine release syndrome, so that's kind of the reason for the toxicity. And there is one medication called etanercept. That's an FDA-approved medication that can specifically block the TNF-alpha pathway, both for the soluble form and also the membrane-bound form. So we have found that by treating the mice in our preclinical model with etanercept, we can actually decrease the neuroblastoma growth. So that's our current ongoing work, and we're trying to make amendment on this current trial to add etanercept to our treatment plan, kind of to block this monocyte supportive role to the neuroblastoma and also the cytokine release syndrome from the TNF-alpha. So this is the current schema or the timeline of the trial. So the TNF-alpha, it's an injection. So we are going to do the subcutaneous injection once a week. So we'll start the etanercept injection the day prior to the cell infusion, followed by every week in the clinic, we'll do 1 injection. A second part of the ongoing work is that, as I mentioned, the NKT cells is not like it recognizes the same molecule among all human beings, which make it a possible target or possible candidate for off-the-shelf therapy. So we're currently trying to get grant support for this type of work, this part of the work, to generate the off-the-shelf NKT bank. So when the patient comes to us, we don't have to do apheresis and have to have them wait for 8 weeks. We'll have the cells ready to go. So this eliminated apheresis procedure, and also the patient can be treated if immediately. I think most important because those are going to be the cells from healthy donors, and we know the quality of the cells, so that can decrease. One of the variable factor is, does different patient cell quality affect their response rate? So in conclusion, I have shown you that our clinical trial of the GenaKit have some anti-tumor efficacy, including 2 partial responses and 1 durable response. And we do think the tumor microenvironment is important, and we're trying to target both the microenvironment as well as the tumor itself with the amendment of etanercept. And the long-term goal is to develop the allogeneic off-the-shelf CAR NKT product for the patient. So this is acknowledgement. So first, like everybody in Leonid's lab that's like actively contributing to the preclinical work, as well as our GMP in the Cell and Gene Therapy Center, and various funding sources, as well as all the patients and families. The second part of the work is going to be a trial that's not open quite yet. Hopefully we'll open it by the end of the year. So it's another cell therapy trial of a combination of 2 different immune cells. One is this IL-15 NKG2D NK cells as a conditioning for the tumor microenvironment. Then we treat the neuroblastoma with the GD2 CAR T cells. So the scientific PI is Dr. Robin Perahar, and the clinical PI is Dr. Shobha Navai. As I mentioned earlier, we think for neuroblastoma, the microenvironment and the stroma cells in the microenvironment are very important, and they're playing a negative role in inhibiting the immune cells go in there and kill the tumor, and also they help with the tumor metastasis. So there are different types of cells that in the stroma cells, such as the myeloid-derived suppressor cells, Tregs, and macrophages. All the cells, they create barriers for the immune cells to go in there and work, and also they're contributing to the cytokine release syndrome that we see with cell therapy. So Dr. Robin Perahar, he's interested in utilizing the natural killer T cells. So you hear a little bit from the earlier talk that the natural killer T cells, they're different from T cells, but one of the advantages, they do have this NKG2D molecule on their surface, and neuroblastoma, as well as the stroma cells, they have the ligand for the NKG2D, which means the natural killer cells can actually directly kill the neuroblastoma as well as the stroma cells. So they can have direct killing, they can promote the immune activation, and also NK cells is not restricted by the HLA molecule, so we can create an off-the-shelf bank from a healthy donor and give to the patient. And people have used NK cells for other trials, and in general, it's pretty safe. We don't see the cytokine release syndrome in those trials. So this trial is based on the hypothesis that there is a synergistic role of the NK cells with the CAR T cells. So the NK cells go in there, kind of conditioning the microenvironment in the tumors, so when the T cells go in, they can be more efficient at killing. So this is a phase 1 trial. Since we have 2 cell products, it's going to be a fixed dose of the GD2 CAR T cells, and that's going to be autologous from the patient. And there will be a dose escalation of the NK cells that's allogenic, meaning the cells are from a donor and it's already stored. Regarding the T cells, the GD2 CAR T cells in that trial, we used in that trial, it has been tested in a different clinical trial from Baylor. So in this trial, basically, we treat patients with GD2 positive tumors, including osteosarcoma as well as neuroblastoma. So among 11 patients we treated, 3 patients had neuroblastoma. And you can see for those 3 patients, that arrow point, 2 out of the 3 patients has a PR, and 1 patient has a progressive disease. Additionally, when you look at the CRS rate, the cytokine release syndrome, we did see some grade 4 CRS that does require steroid to kill off the cells. So this is the timeline of the treatment part of the trial. So first, we do a clinical assessment and procurement, meaning we take your cells, your T cells from the patient and manufacture in our GMP facility. That takes about 2 to 3 weeks because they don't require this autonomous growth. So that's why it takes less time than the GeneKit trial. Then we give lymphodepletion followed by the NK cells 5 days prior to the T cell injection. And then after the T cell injection, we evaluate the patient once a week in the clinic, and then we'll do a disease evaluation after the 4-week period. So regarding the timeline of overall when the trial is going to start, so we already have the NK bank created and tested. So we have the clinical vector, and also we already submit our PRC and IRB. Hopefully this summer we'll start the FDA IND submission, and by the end of the year or starting next year, we can start the trial. And so this is the scientific team as well as a clinical team for this trial, and this is everybody that's involved in the NK cell story here. And that's it.
Thank you. Thank you, Dr. Tian. Does anyone have any questions? I think everybody's questioned out for the day. Anyone? Okay. Oh, one question.
You said you use like on the shelf as like a last-ditch effort. I know you probably can't like publish any data on that, but have you guys seen any like change in disease from anything like that, where maybe somebody just got more time or?
We haven't done the off-the-shelf. We haven't, we don't have the IND submitted. That's something we're trying to like get grant and then work on it. We did have a trial of a CD19 CAR that's allogenic and to treat leukemia and lymphoma. We did see responses, even though after the patient get like frontline CAR T cell treatment and relapse, when we give the CAR NKT, we still see some people went to remission. Okay. And also, I think the most important is we did not see graft versus host disease, meaning the cell product we give, it's safe.
Okay.
Yeah.
So there's no data really either way on it? Like,
we don't have it for the neuroblastoma trial,
yeah,
correct.
Okay, perfect. Thank you.
Okay. Okay, one more question there.
In your previous T-cell versions, you were having issues with persistence and expansion. Has that been addressed with this newer T-cell?
So the question is, like how's the persistence and how the persistence are in the GeneKit trial?
Well, in the previous versions of the NK or T-cell trials you've had, it's my understanding it didn't last very long, and the expansion was.
We did see some persistent expansion, usually because we only had 3 patients, so 3 patients with neuroblastoma. I think in general, we see if the cells persist longer in the patient, we see a better response. If you compare the responder.
No, I'm just saying that has been an issue in the past. It hasn't been.
Yeah, so the issue is we're trying to make the cell persist longer. So as part of the approach to make it persist longer, that's why we changed the manufacturing protocol.
Okay.
So hoping that the cells will persist longer, but I think once you reach certain threshold, his cells just like keep replicating in the body and uncontrollably. Yeah, so that's why we revert back to the old or the previous manufacturing protocol for the safety reason.
Okay, thank you.
Yeah.
Thank you. Okay, that'll be it. Okay, thank you. We're gonna take like a 5-minute break or so.